All right, let's talk about the GI exam. We're going to build the ultimate high-yield guide to absolutely mastering it. If you're prepping for clinicals or staring down your final exams, this is your roadmap. We're not just aiming to pass, we're aiming to excel. So let's get right into it. So picture this. It's a classic scenario, right? The one that walks into your clinic or the ER every single day. A patient is clutching their abdomen, they're in pain, and suddenly the list of what it could be feels a mile long. It can be totally overwhelming. But the key, like with everything in medicine, is having a system. And where does that system start? Well, it begins long before you even think about touching the patient. It all kicks off with the history. Seriously, this is the blueprint for your entire workup. It's the foundation for everything else. Get this right, and you're well on your way. So let's break down exactly what that blueprint looks like.
Okay, for any kind of pain, but especially abdominal pain, Socrates is your new best friend. I mean it. This mnemonic is an absolute lifesaver. It forces you to be systematic. You're asking about the site, the onset, the character, all of it. So think about it. Is the pain sharp, like a knife? That could be a perforation. Does it bore through to the back? Now you're thinking pancreatitis. See, this isn't just a boring checklist. It's practically a diagnostic algorithm right there. Now, some symptoms, they just can't wait. And right at the top of that list in GI is dysphagia, difficulty swallowing. You have to remember this. When a patient tells you they have trouble swallowing, that is an immediate major red flag. Your clinical alarm bells should be going absolutely wild. This one needs urgent investigation, period. So the very first thing you need to do is figure out the type of dysphagia. And you do that with one simple, powerful question. Do you have trouble swallowing solids, liquids, or both? Think about it. If they say it's mainly solids that get stuck, you're probably dealing with a physical blockage, right? A mechanical cause. But if it's solids and liquids, right from the get-go, your brain needs to immediately shift gears to a neuromuscular problem. That one question is a massive fork in the road. It helps you slash your list of possibilities in half, just like that. Okay, so we've got our history, which is our guide. Now it's time for the physical exam. But hold on, we don't just dive straight for the abdomen. Nope. You'd be amazed how many GI diseases write their stories all over the rest of the body. This is where we have to become like clinical detectives, hunting for clues in some pretty unexpected places. Seriously, just look at the patient's hands. They can be a total treasure trove of clues. You see nails that are kind of spoon-shaped? That's koilonychia, and it's screaming iron deficiency. What about white nail beds, leukonychia? That points you towards low protein, maybe from liver disease. And the big one. You ask the patient to hold out their hands, and you see that classic flapping tremor. That's asterixis. You are literally witnessing a sign of hepatic encephalopathy. You can start building a pretty solid differential diagnosis before you've even touched their belly. And the clues just keep coming. Look at their face, look in their eyes. Yeah, jaundice is obvious, we all know the yellowing. But what about those subtle copper-colored rings in the eyes? That's a Kaiser-Fleischer ring. That's Wilson's disease. Or counting the spider navy on their chest. If you see more than 5, that is a huge red flag for liver problems. Honestly, these are the kinds of spot diagnoses that really separate the good clinicians from the great ones. Okay, deep breath. Now we get to the main event, the hands-on abdominal exam. And listen, here more than anywhere else, the sequence, the technique, it's absolutely everything. There is a right way to do this, and let me be clear, it is completely non-negotiable. This right here is one of the most critical and yet simplest rules you'll ever learn. You must listen with your stethoscope, auscultate, before you start tapping and pushing. Why? It's simple. If you start poking around, you're going to change the bowel sounds you're trying to listen to. It's that easy to mess up. So get this order wrong and you've made a huge fundamental mistake. So say it with me. Inspect, auscultate, percuss, palpate. Always. So, during your inspection, you might see that the abdomen is distended or swollen. This classic mnemonic, the 5 Fs, is your go-to. It gives you an instant mental checklist for the most common causes. It's just a simple, powerful way to structure your thinking from the second you lay eyes on the patient. Okay, this is a super important one. When you're palpating, you might feel guarding, but you've got to know the difference between voluntary and involuntary. Voluntary is when the patient is just anxious or ticklish, and they tense up. You can usually get them to relax with a bit of distraction. But involuntary guarding, that's a whole different beast. It's a real reflex muscle spasm. The abdomen feels rock hard, like a board. That is a hard sign of peritonitis, a true emergency. So think about it. We've gathered all these little clues, right? From the hands, the eyes, the abdomen itself, now comes the real art of being a clinician, connecting the dots. We're going to take these individual signs and piece them together into recognizable clinical pictures. You know, the high-yield syndromes that are an absolute staple of any clinical exam.
And at the heart of so many of these syndromes is this one key concept: portal hypertension. All it is really is high blood pressure in the specific system of veins that drains your gut. But this one problem, this single pathological state, is the engine that drives so many of the most dramatic signs of chronic liver disease.
And the fallout from this is huge. I mean, think of it like a plumbing system that's backing up. The high pressure pushes blood back into the spleen, making it swell up. It shoves fluid out of the blood vessels and into the belly, causing ascites. And it forces blood to find new routes through tiny little veins, creating that snake-like pattern on the abdomen called caput medusa. And most dangerously of all, creating fragile, swollen veins in the esophagus called varices, which can be absolutely lethal if they burst.
Pay attention now, because this slide is pure exam gold. These are the classic special signs, the eponymous signs. Knowing how to do a proper Murphy's sign to check for a hot gallbladder, or understanding something like Courvoisier's law, the fact that a big, non-tender gallbladder plus jaundice probably means cancer, not gallstones, these are the details that don't just secure a diagnosis, they're what really impress your examiners. You see, a really great clinical exam doesn't just give you a diagnosis. It does something more. It makes you a smart and efficient doctor. You're not just ordering every scan under the sun. Your physical findings should directly guide what you do next, making sure you order the right test for the right patient at exactly the right time. And this chart here really drives that point home. Let's say a patient comes in with an upper GI bleed. Well, if your exam was screaming chronic liver disease and portal hypertension, what's at the top of your list? Esophageal varices, for sure. But what if the history was full of anti-inflammatory use? Then you're thinking peptic ulcer disease. It's the clinical context you build from your history and exam that makes your next move a smart one. All right, let's wrap up by tackling a classic exam head-scratcher: Crohn's versus UC. This table boils it all down to the key differences you absolutely have to know. Is the inflammation spotty with skip lesions, or is it one continuous stretch? Does it go through the whole bowel wall, which can cause things like fistulas, or is it just on the surface? Nailing these distinctions is so important for your exams. So you've done it. You've put it all together. You've taken a great history, you've found the signs, you've built your differential diagnosis. But here's the final and maybe the most crucial question of all. Among everything we've talked about, which one of these signs is the one that makes you pick up the phone and call a surgeon at 3 in the morning? Which finding is a true surgical emergency that absolutely cannot wait? Answering that question, well, that's the real-world test. And that's what it truly means to be exam ready.